we've talked about prison, or institutions, if you will, correctional facilities, because I know there's a distinction. I've been educated.
Thank you.
Jails, prisons. Let's say that we've got a system that works, maybe a system that takes them from that initial encounter, maybe transitions them to a correctional facility, and you get the right drug and the right frequency. Now it's time to leave. Now we've got another transition here, which is the transition into the community. If they're on this, well, let's say once every 2 months, aripiprazole or oxal, all right, and it's doing good. They go out. What happens? Typically, what happens?
Well, it depends. Do they have insurance? Do they have benefits? Is there a community provider? What usually happens is there's no warm handoff. They leave the facility, and it's at all the facilities, whether they're leaving a civil state hospital, a jail. There is no collaboration or coordination with the community provider.
And early on is we usually see the system fail. So if they do leave on a long-acting injectable, with the medication actually in their muscle versus a bottle in their pocket that usually doesn't stay with them, you have a much better chance of getting them into treatment during that treatment window than you do when you're trying to have them take a pill on their own every day.
In Albuquerque, as mentioned, we work very closely with the county. And the number one thing that the county wanted to work on was on the reintegration center, a place where the individual actually is transported from being incarcerated to this place. And then at that point, the proper follow-up is arranged, the proper medication. And that actually has decreased the number of recidivism back to prison, or for that matter to the hospital.
I get confused very easily, and here I am confused. In this regard, an inmate leaves this facility, and I don't see there's a missing link, right? There's who's there to do that,
Right,
to take that person.
The question is who's responsible.
That's, I guess, what I'm getting at.
That's what's needed.
And that's what lacks. But you
centers.
know what? With advanced technology, it shouldn't be that hard today. We should be able to integrate these systems. We should know who the treatment provider is, where they're going, and there should be a follow-up system. And that's what we're trying to create in Miami right now, and we're getting very close to doing it. It's doable, but there's so many different people who are responsible for different things. There's not one person responsible for the whole system.
I was getting at the mechanism.
But even before we get to advanced technology, because we talked about money being an issue for many correctional institutions, it is possible. So in Cook County, we were able to collaborate with a community mental health provider. Everyone in our facility that has a diagnosed mental illness is released through one area of the jail. And that community mental health provider is at that point of release doing an assessment before the person leaves to review their release plan and determine what they need in the community. They arrange for an appointment. And if they need more services, if they need more time with the individual, we then transfer them to a supportive release center that we, again, collaborated with the community mental health provider. It's outside of the jail, and they receive a more comprehensive release plan.
But that's the problem. So there's about 3,200, 3,700 counties in the United States. And as they say, if you've seen one county, you've seen one county. And community mental health is county-based for the most part. And so there's not a switch to flip to fix this. You have to go county by county to put in these systems in place. We're part of a major initiative called Stepping Up, where we're working with counties around the United States to help teach them how to do this. But it is an enormous task.
But let me emphasize this point. I had mentioned the reintegration center, but I think what is key, and we also do in Albuquerque, is actually for the mental health services to go into the
jail.
Into the jail
Or the prison.
before
Yes.
the patient is released. I think that is
I'm
absolutely essential.
going to take
It is.
a wild guess, and this is crazy. I'm going to guess the person who's doing this reintegration is swamped, overworked, underpaid, and is crazed. They don't have a lot of time per discharge.
They don't. But that's why it's important to have something like a reintegration center or a supportive release center, so you have the ability to spend a little more time with the person to get that comprehensive release plan at place. So in Cook County, we started our supportive release center in July of 2016. To date, we've seen more than 700 people that go there. They get a warm shower, a warm meal, a change of clothes, and a release plan, and we follow up with them in the community. So that's important.
I heard another comment here that I really want to bring out just for a moment. You don't give them the shot and kick them out. In other words, there's got to be some ramp-up time. What is the delay between injection and full effect of these injectable every 2-month
Well, we
antidepressants?
really look at injection and then effect. So most of these patients, especially when they're leaving, are already on an oral agent. They're going to transition. So there may be some what we call oral overlap, where they have a few weeks where they may need to stay on the medicine once they get the injection. Some can be much more quick than that and don't need this oral overlap. But whatever it is, it's nice to start earlier in the program. And the medicine, when it's injected, if you talk about Lorax or the others, within a few days it's in your system, and usually within a few weeks it's effective. So when you have a 2-month injection or a 3-month injection, very early on you have an effective medication with this patient. Now it stays with the patient while they transition.
That's what I was getting at. In other words, I heard this mentioned. I wanted to just bring it out for clarity. You can't start the day of discharge. Correct. You've got to do this and ramp it in.
And there's no blueprint. There's not a protocol for these systems for a community. And so people are having to figure it out one at a time and not necessarily using this information on how to develop it.
Following on the colleague's point, they're actually not all long-lasting antipsychotics are the same. There are some even within our aripiprazole where you have to give additional PO medication, but there are some new products where you don't have to. That right away you give the injection and it goes at levels early on higher and then it stays. So they're not all the same. Some have advantages. This would be an advantage.
Okay, who actually can administer this? I know we've been talking about the clinicians and various caregivers, but who actually can administer once every 2 months aripiprazole to the patient outside? Because you said it was the nurse or some other caregiver. Outside, who does that? Did you say a pharmacy can do it?
Absolutely.
Who else can do it?
So they have centers that you can go to get injections. The doctor can do it. We have many doctors that do it right in their private office. It's a very simple injection. And then we have nurses. So the delivery of the injection is by far not a problem.
What
It's
happens
actually
if
getting
you miss an appointment?
Well, if you miss an appointment, there's often leeway with these medicines.
That's
and
what I was getting
depending
at.
on the medicines, you can miss it for a whole month and then just take your next injection,
Right.
specifically the aripiprazole,
As opposed to
Loraxone.
if you're taken by mouth. If you take it by mouth and you miss it within days, the symptoms will go back.
Remember-
And with the injectables, it takes a longer time for symptoms to come back.
50% of the people with mental illnesses in the criminal justice system are homeless. Getting them to their local Walgreens or CVS is not as easy as it sounds. They are
Doesn't
not
sound
as
easy.
sophisticated because of other issues. Some of them have been psychotic for long periods of time and have cognitive issues. And so you have to have warm handoffs. It's better to do it for them before they leave and then have a case management system in the community that can help them navigate these systems.
There's an